Hello, class. This is Mrs. Marjorie Allen, and I am going to do your video for the NUR 112 oxygenation concept. This is for your COPD and asthma medication chart ticket to class that you need to complete. So go ahead and get that out, and we'll do this together. So your first block here is for your bronchodilators. We're going to go over this together, so let's go through this. You are going to fill this out together as we talk through it. So the first one is the bronchodilators. We're going to talk about 3 different bronchodilators. We got methylxanthines, beta-2 adrenergic agonists, and anticholinergics, also called muscarinic receptor. So your methylxanthines, these aren't used very often. You might also see them called xanthines. The medication that we're going to talk about is theophylline or Theo24. This is a long-acting medication. So the purpose in that purpose box, this is, there's 3 different things I want you to know about it. It's a long-term control for chronic asthma and COPD. It's for bronchodilation. And it's used only when other treatments are not effective because there are some pretty nasty side effects, and it has a tight control that has to be used. There's tight control for it, so it's not used very often. So the side effects of the methylxanthine, the theophylline specifically, are tachycardia, bleeding, nausea, diarrhea, restlessness, cardiac dysrhythmias, that bleeding was intestinal bleeding, decreased clotting time, hyperglycemia, and leukocytosis. But the big thing that makes methylxanthines not used very often under your nursing consideration, the big thing is it's monitor for toxicity. You have to monitor the theophylline serum levels. It has a very tight range, so they can become toxic very quickly. So we advise patients to avoid caffeine. And if they're a smoker, nicotine increases the metabolism of the methylxanthines. So we might have to adjust that dose if the patient smokes. So it's very hard to control that tight range. So methylxanthines aren't used very often. So they only use it if all the other bronchodilators are not effective. So let's talk about the beta-2 adrenergic agonist. I think you guys might have learned it in your pharm class as a sympathomimetic. The two that we're going to talk about are a short-acting one and a long-acting one. In your ATI book, that is a short-acting beta adrenergic agonist. So that's a SABA, S-A-B-A. And the long-acting one is the LABA, L-A-B-A. So the short-acting one that we're going to talk about is the albuterol or the Proventil. This is your rescue inhaler. The long-acting one is the salmeterol or the Ceravent. So that's your SABA and your LABA that we need to remember. So the purpose of these beta-2 adrenergic agonists are bronchodilation, because it's a bronchodilator. It relieves bronchospasms. It increases ciliary motility. And it's selective to lung beta-2 adrenergic receptor sites. So there are beta sites in the heart and beta sites in the lungs. So when you hear beta-2, you have 2 lungs. So think of that. So your side effects of the beta-2s are tachycardia, because you know albuterol is going to make you feel like your heart's racing. Tremors, make you feel shaky. Nervousness, dizziness, anxiety, hypertension, and flushing. Those are some pretty common side effects when they're using a SABA or a LABA, but especially the SABAs. Your nursing considerations, you're going to monitor that pulse and the blood pressure. Advise the patient to avoid caffeine because the caffeine is just going to increase that. Ceravent is the long-acting beta-2 agonist and has a black box warning. So go back to your farm book and look at that black box warning. So the third bronchodilator that we're going to be talking about are the anticholinergics. ATI calls it the muscarinics. So that's where you get the SAMA and the LAMA, the short-acting muscarinics, the SAMA, and the long-acting muscarinics, the LAMA, the SAMAs and the LAMAs. So you got the short-acting beta, the SABA, and the long-acting beta, the LABA. The short-acting muscarinics, the SAMA, and the long-acting muscarinics, the LAMA. That's a way to remember those. So your short-acting muscarinic is your ipratropium, the Atrovent. That's the one to remember for that. The long-acting muscarinic is your tiotropium, your Spiriva. That's the long-acting one. So the purpose of your anticholinergics or your muscarinics is, again, bronchodilation because it's a bronchodilator, to decrease pulmonary secretions, relieve bronchospasms, especially with COPD, to help with allergy-induced and exercise-induced asthma, and the long-term maintenance of bronchospasms with COPD, like a Spiriva, the long-term maintenance. Your side effects of the anticholinergics, they're going to dry everything up. They're going to have a dry mouth. They might even have hoarseness because of that drying up. So like when you document in EPIC and they talk about a hoarse voice, hoarseness. Oral ulcerations because they're inhaling these things. A headache, insomnia, and urinary retention because it's drying things up. So your nursing considerations, they need to rinse their mouth with water after use. If they're doing more than one puff of this medication, they need to wait at least 30 to 60 seconds between the puff of the same medication. So that's education from the nurse. Increase their fluid intake unless it's contraindicated. If you've got somebody who's at risk for fluid overload, we don't want to tell them to increase their fluid intake. Encourage them to suck on hard candies to help with that dry mouth. So those are your bronchodilators. So we have just filled out this whole top section of your chart. All right. Let's move to the corticosteroids or the glucocorticoids. These are long-acting unless they're given in an IV route. So these are long-acting. So we have three different types of your glucocorticoids or your corticosteroids. We have an inhaled corticosteroid that can be abbreviated ICS, your oral, and your IV. So we've got a few examples of each kind. Your inhaled corticosteroids are your budesonide, which is Pulmicort, your fluticasone, which is Flovent. Those are the inhaled kind. The oral one, we just have one example, prednisone, and the other form of that is prednisolone. And the IV kind, the hydrocortisone sodium succinate, which is Solu-Cortef, and methylprednisolone, which is Solu-Medrol. Those are given sometimes for a short-acting thing, sometimes in an emergency situation along with the albuterol. So the purpose of the corticosteroids or the glucocorticoids, they are to decrease airway inflammation because it's a steroid. They suppress mucus production. They decrease the peak flow variability. So that peak flow can be not as good one day, better another day. So these steroids are supposed to decrease that variability, make it a little more stable. They promote decreased frequency and severity of the exacerbations and attacks. So not as many exacerbations. The ICS, the inhaled corticosteroids, and the IV improve the signs and symptoms of COPD, but they don't slow it down. COPD is going to progress. There's no cure for it. So the inhaled corticosteroids and the IV corticosteroids, they will improve the signs and symptoms of COPD, but they're not going to slow it down. So when somebody is having those signs and symptoms and they use the Pulmicort, the Flovent, or the Solu-Cortef and the Solu-Medrol, it's going to improve those signs and symptoms. It's going to improve that shortness of breath. It's going to improve all of those things that they take the medication for, but it's not going to slow it down. So what are some of the side effects of these corticosteroids or the glucocorticosteroids? Some of the side effects are, again, hoarseness because they're inhaling it, candidiasis, which is thrush in the mouth, hyperglycemia. These glucocorticosteroids can shoot somebody's sugar through the roof in a heartbeat. You have got to be checking their sugars on this. Decreased immune function. Again, if their sugars are high, they're going to have a decreased immune function. Muscle weakness, bone loss. And what's another term for that? Osteoporosis. Edema, weight gain, and hypokalemia. Their potassium can be low especially if they're on long-term steroids. If they are on an inhaler all the time, every single day, we got to keep a check on that potassium. So what are we going to do? What's our nursing consideration if somebody's on these meds? Again, we're going to rinse their mouth after every use. Because of this candidiasis, they could get thrush really easy. That sugar just resting in their mouth. Monitor for the white patches and the sores, the redness in the mouth, so they don't get those ulcers. If they're using two different inhalers, like they're using a corticosteroid and a beta and a bronchodilator, which one do you do first? Well, you need to do the beta-2 agonist first, that bronchodilator first, and then do the glucocorticoid, because you got to get the bronchodilator in there to open everything up before you can calm it down. So again, we've got to open everything up before we can calm it down. And then if they're taking 2 puffs of a bronchodilator, they've got to take that 1 puff to open it up, then wait 30 to 60 seconds, take that next puff, because when it'll go deeper the next time and open more up at a deeper level in their lungs. So that's a lot of education from the nurse. Again, we're going to monitor those potassium levels. We're going to monitor the sugar, the blood sugars. We're going to report any black tarry stools. And big thing here, we have to teach them that it might take 2 to 3 weeks to reach some effective levels. So they might, because this is a long-term, unless they're getting the IV route, this is a long-term inhalers, it's not going to work immediately. So they might take 2 to 3 weeks for them to get the full effect of this medication. It's not for emergency use unless it's that IV route. So we have now finished this whole front page. We've done the bronchodilators and the glucocorticoids, so the corticosteroids. So let's look at the fixed combination, your fixed combination respiratory drugs on the second page here. That is your combination of a long-acting medication and your bronchodilator. So these are going to have the same purpose, the same side effects, and the same nursing considerations as your glucocorticosteroids. So all of that's going to be the same. But the examples of the medications are going to be different. So your examples of your medications are the fluticasone and salmeterol. Those two together are Advair. Your ipratropium and albuterol. Those two together are your Combivent. Your budesonide and formoterol. Those two together are Symbicort. And fluticasone and vilanterol. Those are your Breo Ellipta. So those are your fixed drugs. You have a long-acting and a bronchodilator put together. So now we're looking at the leukotrienes. Your leukotriene receptor antagonist. The example of that is your montelukast or your Singulair. This is a long-acting medication. Obviously not going to be a fast-acting one, not going to be for an emergency. The purpose of this is to suppress inflammation, bronchoconstriction, to make everything calm down in there. It suppresses inflammation, suppresses bronchoconstriction, suppresses edema, suppresses mucus production. It's an alternative to the inhaled corticosteroid for mild asthma. So if somebody's not using an inhaler and they just have mild asthma, they might put them on Singulair. But they might also add it to a corticosteroid for severe asthma. Maybe the corticosteroid that they're on, maybe they're on, I don't know, maybe they're on Pulmicort, the budesonide, the inhaled corticosteroid. Maybe they're on that and they have severe asthma and that's not enough. So they'll add Singulair to that. So that's another reason for Singulair being prescribed to them. The biggest side effect of that is maybe nausea and a headache. Your nursing consideration for Singulair is to give it once daily at bedtime. So hopefully they give it at bedtime to sleep through the side effects. And to report a lack of response, because if they're not responding to this medication, that could indicate a decreased responsiveness to therapy. They're not responding to the Singulair, then that might mean that they're not improving, and that's a sign that their COPD or their asthma is worsening. So we're moving on now. We've almost got this chart filled. Now we're talking about mucolytics. The two mucolytics that we're going to talk about are guaifenesin, Mucinex. Even though sometimes that might be labeled as an expectorant, we're going to put it as a mucolytic here. And the acetylcysteine Mucomyst. Those are the two that we're going to be putting in this mucolytics here. The purpose is to increase a productive cough. That's why Mucinex is technically an expectorant. And to liquefy and thin the lower tract secretions. That's the mucolytics purpose. So some of the side effects of these mucolytics are drowsiness, headache, GI upset, rhinorrhea, just some irritation in the nose, and bronchospasms. So they're not usually going to take these for a very long time, but so your nursing considerations for this: do not give to children under 6 years old. The Mucinex is that's for the Mucinex. It can cause airway constriction. So if they have chronic lung conditions, and beta blockers can be an issue if they're on a beta blocker also. So they can cause an airway constriction because that's one of the side effects of the bronchospasm. Sometimes they smell like rotten eggs. It's lovely when you're going to take these. Sometimes you got to take it with a chaser. Lots of water, lots of water. The acetylcysteine is also the antidote for an acetaminophen overdose. So that's just a little side note. Your immunizations and vaccine box on here, immunizations and vaccine. The ones that we want you to know that we're talking about specifically for this are the flu vaccine, the pneumonia vaccine, the COVID vaccine, and the RSV vaccine. So the purpose of your vaccines, each respective vaccine will help prevent the COPD and the asthma exacerbations by preventing respiratory infections. That's why they're going to take your flu vaccine, your pneumonia vaccine, your COVID vaccine, and your RSV vaccine. The reason why you do all of these vaccines is to prevent that COPD and your asthma exacerbations. And you can prevent that by preventing the respiratory infections. Each vaccine has their own side effects. We're not getting into that here. We're just talking about that they'll help prevent respiratory infections. So your nursing considerations, the flu vaccine is an annual vaccine. The pneumonia vaccine is for people over age 65. The COVID vaccine is considered to be an annual vaccine, according to the CDC. And the RSV vaccine is for people who qualify for over age 60 or for infants. And we'll talk more about the infants more in our summer semester. But that's the extent of what you need to know for the vaccines. And then our last one, your phosphodiesterase 4. You can abbreviate that PDE4. This is your roflumilast or Daliresp. The purpose of this is an anti-inflammatory and a bronchodilator. The Daliresp is the only PDE4 that's approved to treat COPD. And this is used in severe end-stage COPD to decrease the risk of exacerbation. So you won't see this often, but if you see it, this person has severe end-stage COPD. The side effects of Daliresp are diarrhea, weight loss, headache, insomnia, anorexia, and in some cases, suicidal ideation. Your nursing considerations for Daliresp are peak airway bronchodilation response is typically 1 hour after that oral administration. So when you give it, the peak response is usually 1 hour after they take it. So that's when you're going to implement airway clearance techniques. That's when you're going to do whatever you need to do, is usually 1 hour after that oral administration. So that's when you're going to do your respiratory training. That's when you're going to do airway clearance. You're usually going to try to do that 1 hour after you give it. You're going to instruct your patient to report any troublesome side effects or any worsening symptoms. And there we go. We have finished this whole chart. This is an excellent study tool for you to learn the medications you need to know for your asthma and COPD. So definitely study this. We'll talk more about some of these same medications in the lecture, but finish this before you come to lecture, so it's not the first time you've heard these medications. All right, see you guys in class.